This is week 3 cardiac inflammatory disorders. We'll talk about some procedures or diagnostic testing and then a review of some medications. We're going to start off talking about infective endocarditis. The endocardium is the inner layer, and then we are having an infection, usually bacterial, and it affects often the valve, the mitral or aortic valve, but it can affect any valve in your heart. Sometimes it's classified as right or left endocarditis, referring to which valve is affected. Most common people that are going to have this infective endocarditis is going to be people that have a way of introducing bacteria into their system. So IV drug users, this has a high risk with this one if they've had like cardiac devices implanted or if they have structural problems with their heart. People with poor oral hygiene and lots of bacteria in their mouth would also be at risk for infective endocarditis. It does increase with age, so this can be something that happens with advancing age, if they have a compromised immune system, if they're a diabetic, if they've had heart valve surgery, if they've had endocarditis before, if they've had an implanted device. Those are some risk factors for developing infective endocarditis. And then mortality can be high from this, 20 to 40% of the cases um, that range for mortality. And then things we can see in patients when they have infective endocarditis. So new murmur, I want to point that out. So listening to your patient's heart and you don't hear that crisp lub dub closure and you hear kind of like whoosh or blowing or whistling or something telling us that our valves aren't closing correctly. Fatigue, confusion, fever, and then we can have things like splinter hemorrhages, which is red streaks in your nails. You could have ocular nodes or Janaway lesions. So ocular nodes, I'll show you a picture in class, are red lesions or red nodes on the pads and fingers of the toes. And then Janaway lesions are red painless spots on the palms and the soles of the feet. And that can be related to like microembolisms breaking away. You can see the damage and the bacteria on the picture and going to our extremities and causing changes there. So a diagnosis for infective endocarditis, they're going to look at blood cultures, they're going to look at a CBC and see if the white blood cells are elevated. They can do an echocardiogram. Echocardiogram is great for gathering information about the heart. It can tell you the ejection fraction, but it can also visualize some of the structures of the heart. It can tell you about the blood flow through the heart. So echocardiogram can give us some good information about, are the valves closing? Are they closing correctly? Does it seem like there's something wrong with it? And then treatment for this, after we do our blood cultures, they're going to get started on IV antibiotics. This is probably going to be a long-term course when we have infective endocarditis. It's going to take a while. So I've had patients that had infective endocarditis and ended up like having to have a PICC line inserted. And then if IV drug use was the cause of this, they would have to go to a long-term care facility to continue their treatment with antibiotics because we can't give someone with IV drug use history PICC line a direct access. So then they would have to like do their antibiotics in a facility to be monitored. If it's really severe, then they can have a valve replacement or valve repair. We're watching for complications of stroke. We're watching for pulmonary embolism where bacteria has broken away and gone to the lungs, heart failure, and then for dysrhythmias. And then our nursing interventions, we're going to be looking at vital signs. Are we seeing any changes in our patient's vital signs? Do we have an increase in respiratory rate? Could that tell us that they have a pulmonary embolism? Do we see tachycardia? We're going to listen to lung and heart sounds. Do we have a new murmur or are we hearing crackles that might tell us that we have heart failure? Do a neuro assessment to monitor for any neural changes, like are they having stroke-like symptoms like facial drooping, slurred speech, one-side weaknesses. Look at their extremities. Do we see any of those genoays or nodular things, splinter hemorrhages? And then diagnostic test results, looking at our echocardiogram. How is our ejection fraction? What did they find? And then review their history. Did they have any drug use, invasive procedures, implanted devices, surgeries, or anything like that that could have been a portal for that infection to get in? And then administer antibiotics as prescribed, maintain their IV access. Like I said, they might need long term, like a PICC line. And then are they going to need to be on medications for heart failure if that's going to be a potential complication? Do we need to be on blood pressure medications? Do we need to be on different diuretics? Those types of things. And then provide social support. It's going to take a little while for this to resolve. This is not something that's going to be really quickly. Like I said, patients I've had before have had to go to like long-term care facilities to have long antibiotic courses to get this cleared up. And then if drug use is the cause of this, they're going to recommend counseling, maybe some rehab too, some things like that to help them, support them as they try to not use drugs. And then teaching good oral hygiene. I did say that poor oral hygiene could be a risk factor. Letting their healthcare provider know that they've had a history of infective endocarditis. Completing their antibiotic regimen is going to be important. We're going to talk about pericarditis, and that is inflammation of the pericardium, which is the outside protective layer, the tissue surrounding the heart. So it is normal to have a little bit of fluid in that area, so that it can protect and cushion and support the heart. So it is normal to have a little bit of fluid there, but we can have problems with inflammation where we have irritation in that area, where they're complaining of chest pain, where we see a pericardial effusion, when we have EKG changes, and it's kind of global EKG changes across all the leads. And then we hear a friction rub, which is kind of like leather rubbing together, or I've heard people describe it as like pulling Velcro open, like. And so that's sometimes how pericarditis is recognized, as we have a friction rub when we're listening to our patient's heart. It could be infectious or non-infectious. It could be related to different medications. And then we'll watch that video in class about pericarditis. Diagnosis, they can look at EKGs to see if they have any changes. They can look at chest x-rays and maybe see some changes there if they have some things to comparison. Echocardiogram, again, super helpful, so it can tell us about fluid buildup. They can do a CT scan or an MRI also. And then we want to help with pain control, so they're probably going to be on some NSAIDs, some anti-inflammatory medications, maybe even aspirin. Stop the inflammatory process if we know what's happening there. And then we want to monitor for that pericardial effusion. We don't want there to be like lots of fluid building up in that pericardial sac, because there is a limitation to how much fluid can be in there to cushion and protect the heart. And then they'll probably still check out like CK, CKMB, interpronin to make sure they're not having an MI. So those will probably routinely be checked. And then look at blood cultures, a CBC. They could look at inflammatory rates. So they could look at like C-reactive protein, homocysteine levels, just to see if our patient has inflammation in their system. And if a patient does have a pericardial effusion, they will have to do some surgical procedures to help them. And so that's full fluid buildup around the heart. They can do a pericardial window where they do a surgical procedure to take out a little section of that pericardium so we can have some fluid removed. They can also do a pericardiocentesis, and that's where they use ultrasound to put a needle through the chest wall to aspirate that fluid. So cardiac tamponade, also something that could happen, and that's where excessive fluid goes in that pericardial sac, compresses the heart, and then decreases cardiac output. And the patient has tachycardia, muffled heart sounds, jugular vein distension. and that's an emergent situation you'll talk more about in Adult Health 3. For nursing interventions for our patients with pericarditis, monitor their vital signs, um, assess their pain, listen to their heart sounds, look at the EKG. With pericarditis and the EKG, you see global EKG changes, and so that's one way that they can kind of recognize, is this an MI, where we're seeing just changes in a couple EKG leads, or is this pericarditis and we see EKG changes in all of the leads because the pericardium goes around the whole heart. Elevate your patient's head of bed, administer medications as ordered, the NSAIDs, the anti-inflammatories, provide emotional support, tell them to avoid strenuous activity, and then distinguishing or recognizing between pericarditis and heart attack are different. And that friction rub is a big thing with pericarditis, that abnormal sound when you're listening to your patient's heart. Myocarditis, that's inflammation of the myocardium, more common in men and young people, usually triggered by a viral infection. It is one of the leading causes of cardiac death with young adults. So not a lot of young adults are passing away, but when they do pass away, this can be one of our leading causes of it. And then it says between 1 to 5% of people with viral illnesses may exhibit signs of myocarditis. Myo, that is the muscle, the heart muscle that is affected. And then things that they might complain about: chest pain, shortness of breath, palpitations, syncope. And then we might have dysrhythmias, cardiogenic shock, and heart failure could all occur. Looking at your patient's labs again, looking at CBCs, do they have a recent infections, looking at that echocardiogram. They can do an MRI. They might even take a biopsy that is reserved for acute cases, but it would give a definitive answer. Management of complications, maybe they're going to need to have some immunosuppressants, and then they're going to be monitored, and they're probably going to be encouraged not to exercise, to rest for a while. They're going to need EKGs and echocardiograms, follow up to make sure that we don't progress and have long-term problems like heart failure or cardiomyopathy. Worst case scenarios: needing heart transplants, maybe needing defibrillators, needing mechanical support. And then monitoring your vital signs again, watching your patient's cardiac rhythm, assessing for any signs of heart failure. So do we have crackles, shortness of breath? Do we have edema? Do we have ascites? Do we have anything like that that might let us know that our heart is not pumping well and that our body is not getting the perfusion that it needs? So watching for heart failure, administering any medications as ordered. So the immunosuppressants, maybe immunoglobulins or things like that. And then provide emotional support, complete their full medication regimen, make sure they're avoiding strenuous exercise while they're recovering so that they are resting. Switching over to DVTs, we talked about venous insufficiency last class, where we talked about if the valves weren't working well in our patient's legs and they're not able to get the deoxygenated blood back up to the heart, and then things are kind of sitting, and we can see some changes here. So in this slide, we're talking about having a clot in our venous system, usually our leg or our pelvis area. Risk factors for this one: varicose veins, history of DVT, being pregnant or postpartum, advancing age, having active cancer, being on hormone therapy or oral contraceptives, not moving around. So we talked about DVTs a lot when patients have had surgery, when they're laying in bed, when they can't get up and move around, because that blood can kind of sit there and then it can clot and we can have problems. So sometimes patients are asymptomatic with that, but typically we're seeing redness, we're seeing swelling, tenderness, discoloration, and warmth in one extremity. So we're always wanting to compare, left to right with our extremities. Do we have one extremity that's red and swollen and painful? Sometimes it can often be behind the knee too. So we know that exercise and ambulation is going to be really important, and that's why we talk about with patients after surgery, getting them up and moving around quickly if we can. If we can't do that, we can do the SCDs, which will help to support that blood flow and keep things moving around if they have to lay in bed. Support stockings are also some things that we talk about for patients. I have an uncle that lived in California and then traveled to Florida to visit our other family. And so sitting on the airplane for a long time, visiting our family, noticing that he's having pain and then having redness in one leg. They go to the hospital, find out he has a DVT, give him some medication, and then he's like, decides that he doesn't feel good and he's gonna hop on a plane and go back to California. So he ended up having PE then, because then those DVTs moved. So not the best situation there. Had to have be in the hospital for a while for treatment there. So with DVTs, they can progress to PEs. Some labs that we look at, D-dimer, which talks to us or tells us about fibrogen degradation products produced from clot breakdown. So it's letting you know that you've had a clot. So if we have a positive D-dimer, it indicates risk for DVT. And then they can do ultrasounds to try to image. Prevention, ambulation, DVT prophylaxis. We've talked about some of those things already. So the heparin, Lovenox, which is low molecular weight heparin. And then if patients have a DVT, they might be put on warfarin, which we talked about in pharm class, working with vitamin K, or direct factor XA inhibitors. So we can have heparin IV if really things are pretty significant or concerning, where then we would be monitoring that PTT level. With IV heparin, we'd be following a protocol. There'd be bleeding precautions. And then I already mentioned how DVTs can turn into pulmonary embolisms. Post-thrombotic syndrome occurs in 25 to 50% of the patient. It's a chronic disorder where they have limb swelling and discomfort. They can have leg pain, and then they can have, skin changes and leg ulcerations that can be related to this DVT. Our nursing interventions, looking at our vital signs, noticing if we have any changes, and then assessing our extremities. What's our color, motion, temp, sensation? Do we have pulses? Do we have things similarly left and right? So make sure we're always comparing our left and right extremities. Gentle palpation, but we're not massaging that. We don't want to move that clot. Talked about the lab tests, and then watching for any signs of bleeding if they're going to be on any heparin, low molecular weight heparin, the warfarin, anti-XA medications. And then early ambulation is going to be important. Elevate their legs, wearing compression stockings, but avoiding SCDs on that limb that has the DVT in it. Encourage adequate fluid intake. Dehydration also does increase your risk of DVTs, and then administer medications as ordered. Teaching, we want to prevent reoccurrence of DVTs, so making sure they understand what are some things that could potentially cause it, like sitting for long periods of time, certain medications, being immobile, and then advancing age, cancer, certain risk factors. Signs and symptoms of bleeding, they should know what to watch for. So bleeding gums, blood in the stool, anything bleeding from our nose. We could have bleeding in our brain, which would be more like mental status changes if they had an injury there. And then they should have regular lab monitoring. So if they're on the heparin IV, we're monitoring the PTT or the anti-XA. If they're on warfarin, we're monitoring PT or INR, monitoring those things as needed. And then we've kind of talked about the safety precautions with the anticoagulants. Now we're talking about abdominal aortic aneurysms. So weakening in the area of the aorta that causes dilation. This can often be related to hypertension, where patients have an aneurysm and then they will monitor it. Smoking is another huge risk factor for this to develop abdominal aortic aneurysms. So if we can control our risk factors like hypertension or smoking, that will decrease their risk. There's something called Marfan syndrome in those patients. It's a connective tissue problem. They are more likely to also have aneurysms too. So we want to control our risk factors. If patients do have abdominal aortic aneurysm, sometimes they will monitor them with imaging, ultrasound, MRI, and once it gets to a certain point or a certain measurement, then they recommend surgery where they correct it or fix it. And then might be asymptomatic. Maybe they just find it on imaging or because they meet some criteria for risk factors. If it urgently ruptures or emergently ruptured, they're going to complain of severe abdominal pain or back pain. We would notice an increase in heart rate. We would have a decrease in blood pressure. They sometimes call it like a shearing or tearing feeling. And then we would be monitoring their labs, like their hemoglobin, hematocrit, because the abdominal aortic has like ruptured or it can be bleeding internally, so the blood is in that area instead of being in the vascular system, so we would see a decrease in hemoglobin and hematocrit. So nursing interventions for this, doing a good thorough assessment, how do they describe their pain or what are some symptoms that we noticed, keep calm, so this can be an emergent situation, administer medications as ordered, and then medication compliance to try to prevent these, smoking cessation, maintain a healthy weight, exercise, avoid crossing or elevating legs, that puts pressure up there, reduce stress, and then diagnostic screening for any concerns there. So what's their blood pressure, what's their cholesterol like, what's their blood pressure like, and then ultrasounds. So can be an emergency situation if it ruptures in class. Not a lot of students know him anymore, but John Ritter died from one of these abdominal aortic aneurysm. He was on Happy Days, maybe? I'll have to look. But he was a famous actor that they thought had an MI, and then come to realize that he actually had a triple A and he died from it. So this was quite a while ago because he's an older actor. And then EKGs, we've talked about these before. This is really helping us with patients that are having chest pain, diagnosing MI, because we can see the electrical activity of the heart and how it's functioning. So anyone with chest pain should have an EKG within 10 minutes of it. Who are performing EKGs? Usually it is our supportive staff, so it can be our techs on the floor. Some places lab will come up and do EKGs. Most nurses are also trained how to do EKGs where we're putting the patches on the patients and then running those. Lots of facilities will have this like as a standing order. When patients get admitted, if they complain of chest pain, we can go ahead and do an EKG. So it does not require a lot of like calling or notifying the provider. We would then call them when we got the results. Cardiac lab testing. So we've talked about lipids before in our other classes. These are just repeating the things again. So total cholesterol less than 200. Our HDL is our happy or our healthy cholesterol. The higher that is, the better. And then the LDL, we want that less than 100. Triglycerides less than 150. Myoglobin is an earlier indicator of cardiac injury and can be any muscle injury. CK is general muscle injury, peaks about 24 hours after chest pain, lasts a couple days. And then troponin, any positive value, shows damage to our cardiac muscle. BNP is our lab that we do for heart failure. If that's positive, then we're having a fluid buildup, we're having our ventricles are stretched. So BNP is for heart failure. CKMB, myoglobin, troponin, those are all labs if patients are having chest pain to see if they're having an MI. Other testing we can look at, chest x-rays can give us some good information about your patient's heart, how large it is, what it looks like, and then EKG, great information about your patient's electrical conduction system, echocardiogram, wonderful for lots of different things, but heart failure and our infective endocarditis, and then pericarditis and things like that. Transesophageal echocardiogram is when they sedate your patient and then they insert the tube, the camera, because your esophagus is really close to your heart, and then we just get a much better picture because they have less tissue to go through. A stress test telling us information about the workload of the heart, so putting your body under stress, like having you walk on a treadmill or ride a bike, and then they are monitored to see if there's any changes in EKGs, to see if they have any chest pain at the time. And then heart catheterization or angiography, it's where they're looking at the vessels to see if there's narrowing with plaque or atherosclerosis formation. We've talked a little bit about pacemakers in some of the other classes, like if for the Brady and stuff. So pacemakers would be used for patients that are symptomatic bradycardic that's not responding to other things. And that can happen as our SA node. As our patients get older, our SA node can be less responsive, not working as well. And so we could have slower rhythms that originate lower down like ABE and other areas. So when patients are having a pacemaker inserted, they need to know why they're having it done. They want to know like what's going to happen after. So most places you have to not move your shoulder so much above the side with the side that they put the pacemaker in on, and that's usually wearing an arm sling. There's certain care that they have to be aware of because they're not supposed to go through like x-ray machines for like imaging with flying and things like that because it can affect it. So they get like the wand or the pat down instead. And then we want to make sure that they carry their identification card if they're having a pacemaker put in. Um, they might have some pain after they stay in the hospital for like a day or two just to make sure everything is okay. Pacemaker rep comes and checks their pacemaker the next day, monitor their incision for any infections, and then the hiccups could be related to the settings or how things were set up. And so that's why that pacemaker rep always comes back and checks the patient to make sure that there's no complications. And pacemakers, they can also have defibrillators combined together. So they're really cool actually if you ever get a chance to watch a pacemaker being put in at clinical or defibrillator. These can be life-saving. So defibrillators, internal defibrillators are pretty similar to the pacemaker stuff. We're still concerned about lead placement. We're concerned about not moving your shoulder. We're concerned about the incision. If they have hiccups, it's the diaphragm might be being paced, and so they might need to adjust something. And then they should have an identification card that says they have a pacemaker or a defibrillator. So patient education, they're not able to raise their arm for a couple of weeks. They are taught to take their pulse because it should match up with like the pacemaker settings, report any dizziness, fatigue, um, avoid driving typically, avoid contact sports, heavy lifting, things like that for a little bit because we don't want injury on that chest or where that pacemaker might be. So if they were in a car accident, then it could injure like the pacemaker if they had the airbag deploy and things like that. So that's sometimes some things that we talk about with cardiac surgery too, that they can't drive for a little bit. And then no magnets over the pacemaker, inform TSA, inform any providers. And then if they do have a defibrillator, an AICD, and they get shocked, they can pass out from it. People say that it's really painful. And they should notify their provider if that pacemaker defibrillator does shock them. Cardiac catheterization or an angiography. This is where we're looking at our vessels on our patient's heart. They can go through the femoral groin or they can go through the radial area. Femoral is more common, but radial has less downtime, like where they don't have to be laying in bed and they can go home pretty quickly and different things like that. So looking at the coronary arteries to see if there's any blockages in them. If patients are having unstable angina or EKG changes, they would want to have this done. And then it can be for diagnostics. So sometimes patients need to have an angiography before they have a different surgery. So just diagnostically, like my friend's boyfriend just had a valve replaced and they made him have angiography first to see like, okay, well, if we're going to fix the valve, let's make sure the coronary arteries are okay. Otherwise, we could combine the surgery and do two things at once. His valve was replaced, but his arteries were fine, so he didn't need anything else. And then they can also put stents in, they can put balloons in, they can kind of squish that plaque back so more area for the blood to flow through. And then when we have intervention, it's called percutaneous coronary intervention. This is what they're talking about here. They're inserting a balloon into the artery that has the narrowing and the blockage. They're compressing that plaque. It's opening the lumen and allowing blood to flow through. Then they're going to put a stent in there to keep that plaque opened up. And then they should have relief from their chest pain as blood is able to flow through more freely. If they do have chest pain after they have intervention like this, then we should notify their provider. And then post-cap interventions, we're going to do frequent vital signs for a while. We're going to monitor for sites of bleeding. We're going to monitor for hematoma, check neurovascular status, so check their distal pulses, their peripheral pulses, check their cap refill. And then we're going to monitor to make sure there's no bleeding. They have to stay on the EKG monitoring for a while, continuous cardiac monitoring so we can know what their rhythm is. If they have the femoral approach, they're going to have to lay flat for a while. They're going to be on bed rest. The extremity will be straight. If they have the radial approach, then they're going to have a little band around their arm where it's holding pressure, and then we slowly decrease the amount of pressure that is on that artery. That is the TR band, and then that's the fem stop off to the side where it's holding pressure where they went through the femoral artery. Watch for bleeding with both of these. Watch for any changes in pulse with both of these. Signs of decreased perfusion would be something to notify your provider. And then just mentioning valve surgery a little bit. So sometimes patients need valve replacement, or they could have trans aortic valve repair. So they can have minimally invasive, or they could have very invasive where they're opening up the chest. If they're doing that, they're going to go to cardiac rehab. They're going to go to the ICU regardless of which procedure they have, valve replacement surgery or the TAVR. They need to be watched closely for any bleeding, check their pulses, monitor their EKG, monitor any sites. And then if they're having the valve replacement, they're probably going to be on lifelong anticoagulation therapy. Otherwise, there could be platelets and things that go to that foreign valve that was put into your patient. And then they could have, the valve not working or have clots develop there. So that's why they're going to be on anticoagulation therapy. Valve replacements do not last forever. So if a patient has a valve replacement, they might need another one, a decade later. And then looking at their lifestyle, do they need to make dietary changes? What are some signs and symptoms of valve disease? So syncope, shortness of breath, fatigue, and then they would notice on imaging that the valve isn't working well. And then signs and symptoms of heart failure, shortness of breath, crackles, edema, monitoring their fluid intake, sodium, are they taking their meds? And then often they need prophylactic antibiotics before dental procedures because we don't want bacteria in the mouth to migrate to that new valve or that valve that they fixed. And then they might be really tired, fatigued, so they should rest and energy conservation, plan their activities. So CABG is something that patients can have when they have multivessel disease. Bypass reroutes the circulation due to an occlusion. So often we can fix things with a stent and going to the cath lab, but sometimes patients have multiple blockages and they would do better if they had this surgery instead. So this is a big incision across your patient's chest. This is going to the ICU immediately after surgery. Surgery takes several hours. It's a long thing. And then we have to monitor their respiratory status. Often they're intubated for a little while. And then they have chest tubes that you have to monitor the fluid. Their blood pressure can be kind of like all over the place. So they might be on vasopressors to increase their blood pressure. They're usually on pain control or monitoring their incision for any dehiscence or infection, monitor their level of consciousness because they could have a stroke. So these are really kind of like big surgeries that patients can have. And then if they had smoking, we would encourage them to quit. We would report any signs of infections immediately, avoid stress. They're going to go to cardiac rehab and exercise in a controlled environment while being monitored by a nurse. Sternal precautions, we don't want a lot of strain on that sternal incision that they opened up to get to do surgery. So they're going to be told to use a pillow to brace their sternum. They're going to be told not to drive for a while because if they drove and the airbag went off, it could hurt them, or the steering wheel could open up that sternum. Any sort of chest pain, they'd want to let their provider know, and then they should have dietary modifications for improvement and then exercise. The next couple slides are all about medications. So these are reviews, and we can talk a little bit more about those in class. But those are all medications that you've learned about in pharmacology or that you have covered on the previous exam. So these would be good things to review. They're on your exam also for cardiac exam. And then we have some patient scenarios at the end that we'll talk about in class.